So I'm going to invite the next set of speakers. Colin Tan is going to be talking on anti-VEGF treatment for neovascular AMD as needed treatment PRN. Colin, welcome.
All right. Thank you for the introduction, Lite, and good morning, ladies and gentlemen. It's a great pleasure to be here with you. First of all, I'd like to thank the APAO committee for inviting me to speak. It's a great honor. And as always, I get the easy topic here, so this should be a slam dunk. So let's see what we have to say about PRN. Firstly, these are my disclosures. I do get honorarium from some of these companies, but there will be no conflict of interest, not when I'm arguing for PRN treatment, so don't worry about that. So why PRN? One of the reasons to start with is the cost of treatment. Now, when we look at for the patient, in many countries, patients either pay out of pocket or have some co-payment involved. And for these patients, every dose of injection, every treatment carries a cost. And they want to minimize the cost, quite understandably. Some of them are so concerned about the cost that they want to avoid treatment even when it is indicated, when we can show them disease activity on the OCT scans. So imagine trying to convince these patients to undergo a treatment, which is when it's inactive, which is what treat and extend does. So I found it sometimes difficult because patients would say, why are you treating when there's no activity? You can tell me there's no activity, why should we carry on the treatment? And for the healthcare system, we know, of course, that there are many administrators and bean counters out there who always question, do we really need to spend this money? So how do we justify to them that we're treating patients when there's no disease activity? Whereas if we were to do it PRN, we can definitely show a case that we're treating because there's some activity shown. Also, there's the issue of limited reimbursement. In some countries, the public healthcare reimbursements for anti-VEGFs are limited to a specific number of injections per patient over their entire lifetime. Not per year, but over their entire lifetime. And this is especially so in some countries in Asia. And this may be as low as 7 injections for the patient for the entire life. After that, it's out of his pocket. So even if the patient's willing to undergo treat and extend, he may not be able to afford this. And PRN has the potential to lower treatment burden. Now that may sound surprising, but look at this paper published in the European Journal of Ophthalmology, who showed the mean number of injections for PRN in the top half and in the middle third for treat and extend. For the first 12 months, for months 12 to 24 and beyond, there were actually fewer injections for PRN compared to treat and extend. And the difference in terms of the mean number of visits was only 16.5 for PRN compared to 15.5 for treat and extend. So not that big a difference. This paper also found that the patients in the PRN group had longer mean time between consecutive injections compared to treat and extend. Now let's go on to talk about the patient's perceptions, because this is very important, right? We're dealing with a human being who has their fears, their concerns. So what are they afraid of? Many of them are afraid of injections. I'm sure all of us here have seen these patients. They dread injections and they're in fear of requiring injections. And if you tell them that, okay, I don't need to inject you today, many of them express a great deal of relief. Some of them are even like silently praying to themselves that I'm going to say no. So for those, some have argued for treat and extend is that, well, at least it's more predictable for the patient. They come in knowing that they're going to get the injection, so they're prepared for it. Maybe so, but let me ask you, when you came into this room, if you were coming into this room knowing that you're going to face a firing squad, and I'm the only person who can say no, would you like to come in knowing that you are going to get your firing squad, or would you like me to have that chance that I will say no, not necessary for you, all right? So which would you like, predictability or at least a chance of not having something that you dread? In terms of patient satisfaction, it's also been argued that treat and extend is more satisfying for patients. But in this paper, in a prospective study of 105 patients who had PRN followed by switching to treat and extend, a majority of them considered it to be equally satisfying. So they didn't seem to make a difference. And in terms of compliance, sure, this applies to any patient in any treatment strategy in terms of compliance, but some patients we know are not so compliant. When we go treat and extend, when we're talking Q16, even Q20 in some cases, some of them will then disappear in the system. Do we really want that? We want more frequent monitoring for these patients. Now, of course, the argument may then come that, well, then you're going to see them more often. Remember, one paper showed that the mean number of visits was similar. But we also need to think outside the box. So, and full credit to Dr. Sada for this point that we were just talking about. We need to think beyond just the traditional, all right? We can have more frequent monitoring, but we need not necessarily bring them in to our clinics because there's now increasingly the use of home OCT, so we can actually monitor these patients and not treat. So one of the reasons for treating extend is because traditionally we had to bring them into the clinics, scan them, and then just treat even though they were inactive. But now we have the option of doing home OCT monitoring and only tell them to come in when they actually require treatment. So that's PRN. And also, what is the optimal treatment interval? This is very variable. Some of them, we know patients who can go long periods without requiring treatments. And on the other end of the spectrum, some of them have worsening activity during the treat and extend period. So I submit that it's better to review patients actively and treat only when required. And those with rapidly progressing disease, some people believe that PRN is less proactive than treat and extend, but I say not so, because for these patients, we can monitor them frequently, either in person or remotely, and this treatment can be given even every month if necessary. So to summarize, PRN is good because it reduces the overall cost of treatment, it reduces the number of injections for patients, it reduces the fears, and active monitoring more frequently, how we choose to do it in various systems, allows for individualization of the treatment regimen.